Hello everyone. We are about to take another lesson, which is depression. What is depression? Depression is an affective disorder which may be defined as a subjective feeling of sadness and retardation of mental, physical, and sound activities characterized by loss of interest, happiness, lack of energy, and pessimism. Depression or depressive illness is a mood or affective disorder. In addition, there's an extreme psychomotor retardation characterized by extreme feeling of sadness, withdrawal, and suicidal thoughts. That will take us to the types. What are the types of depression? Type of depression could be classified into three main clinical types. Number one, we have exogenous or reactive depression. Number two, you have endogenous or primary depression. We have number three, we have a secondary depression. Then taking up exogenous or reactive depression, this is also characterized by reacting to catastrophic events. Its etiological factors are said to be by external stimuli, such as depression following bereavement, loss of loved ones, failure in exams, loss of employment, loss of valuable properties, disappointment by spouse, and unhappy marriage. Still under reactive depression is also characterized by neurotic syndrome or symptoms and is less severe. It could respond temporarily to reassurance and change of environment. It is also common to people who have low self-esteem. And that will take us to the second depression, which is endogenous or primary depression. This type, spontaneously, the cause of the illness may be within the individual idiopathic. The person is constitutionally predisposed to depressive illness due to his type of personality or hereditary factors or determinants. It may also be attributed to some sort of biochemical or physical changes in the body, and is also characterized by early morning waking or early morning walking, loss of weight, loss of appetite, and also delusion and hallucinations. You equally have other types of endogenous depression. Under it, we have one, involutional melancholy. This occurs in middle age and later part of life. It is caused by hormonal changes in the body during menopausal states in predisposal women. Predominant feature is agitation, but characterized by complaints of body or mental suffering, restlessness, hypochondrial ideas, and delusion of guilt and unworthiness. The risk of suicide is very high, and this type of depression is common with women. Still under the same type of other type, number two, we have senile depression. This also occurs in old age. It may be as a result of degenerative changes in the brain. It is irreversible and characterized by degeneration of intellectual powers, that is concentration and memory loss, and also loss of appetite, loss of weight, and hallucination. The third one, which is manic depressive illness. Manic depressive illness that has to do with bipolar depression. This is a manic depressive illness characterized by a greater degree of judgment seen in endogenous depression and expresses symptoms of manic and the other time depression, with separation from reality, delusions, and hallucination. And that will take us to the secondary depression. This is a sort of depression linked with psychological or physiological changes in the body. That is old age, menopausal syndrome. And what will be the causes? What are the causes? Number one, we have hereditary factors, that is genetic. Number two, we have biochemical factors due to depletion of amines in the brain, electrolytes imbalance, and excessive production of cortisol by the adrenaline gland. Number three, we have psychosocial factors such as failure in exams, loss of loved ones, divorce, disappointment. Number four, we also have here age, that menopause and old age might result into depression. Number five, we have pre-morbid personality, the personality before your illness. And if you have the trait of madness, it also leads you into becoming depressive, which is secondary. Number six, also have drugs such as metadopal, and some contraceptive that also cause your secondary depression. And what will be the clinical manifestation? This also depends on the role, either manic or depressive state. Patient looks very sad and lack interest in self and environment. There's also he lacks in initiative, poverty. He lacks also concentration. Memory is also impaired. There's also delusion of guilt and unworthiness among the patient. There is also hypochondriasis. Nihilism feels it is not existing. You also have insomnia, loss of appetite, and loss of weight, and sleeplessness. You also have a suicidal tendency. You also have loss of libido, does not have interest in sex. Amenorrhea is also common in women. Speech is monotonous and slow, and almost to the point of mutism. Symptoms tend to worsen in the day and improve as the day goes by. That is a clinical manifestation under secondary depression. And that will also take us to another caption here, which is what is the difference between endogenous and exogenous. Number one, under exogenous, we have your onset is acute. Then under endogenous, onset is insidious. Number two, under exogenous, symptoms are severe or less prolonged. Under endogenous, symptoms are more severe and prolonged. Number three, under exogenous, late insomnia, patient find it difficult to sleep, but sleep all day, nights without disturbance. Under endogenous, patient sleeps early and also wakes early insomnia. Number four, Patient mood is bright in the morning on waking up and becomes depressed as the day goes by. Still under number 4, in endogenous, patient mood is worst upon waking and improve as the day goes by. The last point here, we have exogenous suicidal tendency are highest, especially in the early stages of the illness. Still under endogenous, we have here suicidal tendency are not most frequent. It also occurs at the terminal stage of the illness. And that will take us to the treatment. What will be the treatment or chemotherapy? Number 1, patients are normally placed on antidepressants such as triprazole, triprazole in divided doses, or antidepressant drugs in divided doses, 50 to 30 milligram. Also have imipramine, tofranol. They are also drug of choice that can be used in divided doses. We also have here ECG. This is also useful when this type of patients complain. We also have here psychotherapy. This is to visualize or verbalize the patients and to arouse his interest. That is to say he has a prefrontal locotomy. You have occupational therapy. This is also used to encourage and stimulate patients' interest when patient is agitated. Tranquilizers like Lagatil, Melaril, Stelazil, Valium, and other drug of choice are also being given. And that will also take us to nursing consideration when giving drugs. What are those considerations are you supposed to give, especially with a depressed patient? A patient who is not talking, who is always sat in the ward. These are the following. Number 1, administer drug with food or milk to reduce IG, gastrointestinal tract. Ensure the drug is crushed if patients cannot swallow. You can always ask that question. Can you swallow your drugs? Or I should mash it or crush it for you. These are the questions you ask as a nurse. Number 2, give increased fluid and bulky in diet if constipation occurs. Number 3, whenever possible, full dose should be given at bedtime. If daytime, sedation is a problem. But one patient that orthostatic hypotension may occur. So also assist with ambulation as a safety measure. Relieve dry mouth by giving sips of water, sugar, less gum, or hard candy. Then advise the patient not to discontinue drugs abruptly after prolonged use, as nausea, headache, malaise may also occur. Caution patients on activities requiring alertness. A drug may cause drowsiness, dizziness, blurred vision, and to change position, do it slowly to avoid fainting, especially in elderly patients. Then effect of drugs may take several weeks to disappear. So these are the things that you might also explain to your patient. Instruct patient to avoid alcohol and other central nervous system depressants too. So these are some of the advice that you may give to your patient. Then consult the pharmacist, physicians, and nurse when complication arises. May also increase appetite and possibly craving for sweets. So these are the things that I might consider as a nurse to your patient. So what is nursing management? How do you carry out your nursing management? Nursing management is as follows. It's as follows. Number one, management of the patient should be focused on adequate observation for the prevention of injury on self and others, including staff. Number two, avoid nourishment to maintain good health. No, adequate nourishment to maintain good health, because patients may refuse food in order to starve to death. That is suicide. Try to encourage adequate food. Number three, also improve personal and environmental hygiene, which is very, very important. Number four, adequate rest and stimulation of activities by engaging patients in occupational therapy to encourage his interest with others, which is also very important. Number five, prevention of suicide is one of the greatest skills of the psychiatric nurse, and that of observation and the ability to identify potential suicidal patients. So we have talked about it, and I've even given you an assignment on observation. What are those things that you're supposed to observe? What are the opportunities that you use in observing? So you should know that observation is part of psychiatric nursing. So the next one we have, a nurse should therefore ensure accurate reporting of the patient behavior and also symptoms. So observations and reporting goes hand in hand. As you observe, you put it into paper. That's the meaning. So the next one here we have obstructive and unobstructive observation, which is number 7. It should be encouraged to take and swallow their drugs when safe to them, and also encourage them in a conversation to be sure that the drugs given to them are not hidden under the tongue, which the patient may accumulate to have sufficient quantity to commit suicide. So this is also very important. Most patients will also bury their drugs under the tongue. And when you are that type, or a nurse who is not observant, you tell you open your mouth, you say, we open mouth, but yet the drugs is under the tongue. So as a nurse, you have to be very careful. That's why we tell you some of these things, so that you note them as soon as you get to the ward. So the next one here we have a suicidal caution card should be kept for the observation without the patient knowing that he is being observed, and strictly. So all depressive patients should be handed over physically on every shift. So you try to hand them over physically, whether they are there or not. Try to look for them and then hand them over. You might be handing over and they are inside toilet. Make sure they come out for you to hand them over before they commit another act that will be against you. And that will also take us to the next one, which is the nursing care plan of a patient with reactive depression. Number 1, I may want to treat this. Let me treat this. For the other first one, I gave an assignment. Number 1, we have here under nursing diagnosis. What do you have? You have high risk for violent, self-directed related to suicide behavior. And what will be your nursing objective? Your nursing objective here is patient violent behavior will be controlled within the period of admission. So that is the objective. And the next one we have nursing orders. Nursing orders, what are you supposed to do as a nurse in the ward? Number one, admit patients in a therapeutic environment, quiet and non-threatening. Then under scientific rationale, what are those things that you have put in place? What did it do? What will it do to your patient? The therapeutic environment reduces agitation and then decreases situation in which the individual is frustrated. So those things you do as nursing orders, you now give a rationale behind what you're doing, and that is it. So if you understand care plan, it will be very, very easy for you to treat them and then treat your patient adequately. So the last one, which is evaluation. Patient violent behavior was under control within the period of hospitalization as evidenced by no suicidal attempt. So that is the first objective which I have tried to put in place. And there are other ones too that you think you might do. The second one, under nursing orders, because we have diagnosed, we have taken our objective, and under intervention, here we have remove all instruments that could be used for violence, like what? Razor, knife, belt, rope, and medication should be removed. So those things that you have done, the nursing orders you have carried out, what is the rationale behind that? Number one, we have this instrument, when removed, reduces the chances of self-destruction. Going back to nursing order, number 3, we have assigned one person to stay with the patient at all times. So what would this intervention do to you? Number 3, under rationale. This provides surveillance the patient's needs and give him the feeling that staff both understands his needs and is concerned. That is the rationale behind that. Then the number 4, what will you do in nursing orders? You have provide meaningful activity to let out tension and hostility. Example, playing football and tennis and table tennis. If you have those things, you need to provide them for the patient for them to be free. So what will be the rationale of carrying out those activities? Here, activities provide opportunity for him to see that he is worthwhile person, and it's also allowed him a medium for expressing his feeling of aggression and hostility. So the list thing here, the last but not the least, we have here give prescribed drugs. That is the last thing you would do as a nurse, because you have actually displayed what you can do, your intervention, your rationale. So the last one that you have to do is give prescribed drugs. Example, we have drug of choice, which is a Lagatil. So what will be the rationale given those Lagatil? The chlorpromazine, which also acts by reducing the patient's activities and also lessen the risk of suicide. It will also act on the central nervous system and make the patient to be calm. The next one here, which is the number 3, I will allow you to go and look at it. It's also an assignment attached to it. I have tried to treat the first and second, so go and treat the third one, which it is also stated in your textbook. And that will bring us to another lesson, which is called involutional melancholy. Involutional melancholy is a word that we have mentioned time without number. It is a condition characterized by depression or sadness occurring during or after the menopause in women and when sexual power declines in men. It is more common in women, perhaps because the end of childbearing period leaves some women with no apparent purpose in life. What will be the clinical feature? What is the clinical feature? Number 1, we have marked agitation, delusion of persecution, They may attempt suicide, always feeling insulted, very conservative, early flowing of tears. They like crying a lot. These are the clinical features. Then treatment. What would be the treatment that they are supposed to give to an involutional melancholy patient? Number one, ensure that responsible relative can supervise, then arrange for inpatient care. Ensure hydration and nutrition. Precaution to patient suicide. Precaution to prevent patient suicide. Then refer if condition deteriorates immediately. Refer to other bigger hospital if condition deteriorates immediately. So we also have other ones that we have talked about. General factor of psychotic disorder, which we have also talked about in general symptomatology of mental illness. But I could just mention them so that we have a thought of it. Under general factor, we have consciousness, affects, behavior, thinking, perception. And I've also tried to mention them here too. But I would not repeat them because I've said it in other lecture. So read them up and know why it is important. And that will take us to puerperal psychosis. You have been hearing puerperal psychosis, and you might be wondering, what is puerperal psychosis? This is also known as postpartum. It's also known as postpartum psychosis. It is a severe type forms of mental illness affecting the whole personality, occurring immediately after childbirth. What is the causes? Number one, we have febrile illness after delivery, postpartum hemorrhage, toxemia of pregnancy, hypertension, epilepsy. Women who have had a previous mental illness are more likely to develop postpartum psychosis, especially women too who are pregnant and cannot go to the hospital for maybe antenatal care, and if they have the trait of madness before, it trigger their illness and then lead them into having puerperal psychosis. What will be the symptoms? Signs and symptoms of puerperal psychosis. We have here hallucination, delusion, mood disturbance, may become quiet and withdrawn. Occasionally, the infant may be neglected as the mother is incapable of looking after her child. Then what is the treatment? They need special attention should be given to the care of the infant. The period of separation should be as short as possible so that the woman can go back to taking care of her baby. Also ensure hydration and nutrition. Maintain flow of milk so that the baby can feed. Also show sympathy. Give tranquilizers. Example, diazepam, which is also common among us. And refer if no response in 2 weeks. If no response in 2 weeks, there's no need to keep the patient. Refer the patient to tertiary institution where you have doctors and other people that can support and treat them very well. Thank you for listening. And that will also take us to another topic, which is acute confusional state. Acute confusional state that can also be called delirium. This is also described as an acute confusional state under organic psychosis, though it is irreversible. It is a condition of rapid onset, usually reversible, in which a patient is unable to perceive his environment. Confusional states last from few hours to days and weeks depending on the cause. Clinical manifestation. The most striking is the disturbance or cloudiness or consciousness. The patient is disoriented in time and place. There is also anxiety, aggressiveness, and insomnia. Short attention span and concentration span. There is also loss of memory for recent and past events. These are some of these conditions that you need to witness and also see them as something you can go after because it occurs oftenly. So there's also restlessness. There is also mood fluctuate between depression and elation. Terrifying dreams interrupt his sleep. Delusion occur when flux on the bed changes into small animals crawling, and the cracks on the walls assume moving faces. These are all what he dreams about, which is not real. They are frightening visual hallucination, which causes him to panic and also become violent. There's also speech is incoherent, irritability, and confusion. The patient initially may complain of headache, pains, perception, flushed face, and malaise. There will be also the presence of fever for days, and patient may become over sensitive to noise and light before he finally goes into delirious state. He goes into delirious state. Etiology. What is the cause of it? Acute confusional states can occur in a variety of conditions. We have infection. Any systemic infection with high fever may cause mental confusion. For old people and drunks are more vulnerable. We also have encephalitis and also meningitis, influenza. Pneumonia are also common causes. Here we also have metabolic disorders, hypoglycemia, hyperglycemia, hepatic failure, and also uremia, electrolyte imbalance are common causes. The next one we have nutritional deficiency, where you have deficiency of vitamin B, B6, B3, B12. Intoxication from drugs. We also have here barbiturate, alcohol are also cause of intoxication or drugs of intoxication. Also have disease conditions like congestive cardiac failure. These are all parts of the causes. You have trauma, head injury from road traffic accident or direct blow to it, which may lead to post-traumatic injury. We also have here tumor. We have cerebral tumors that are also found in the brain. We have senile or insenile dementia. We also have cerebral malaria, cerebral abscesses, puerperal psychosis, hypoxia from any cause, poisoning as well, example, carbon dioxide poisoning from pulmonary diseases. You have also drug withdrawals, alcoholism, barbiturate, narcotic. And the last, we have cerebral vascular accident, which may also affect the brain. And that will lead us to the next one, which is management. How do you go about the management? Management consists of removing the primary cause, but systematic treatment is also required. It is usually an emergency situation. The patient is admitted in a quiet and calm corner of the ward with familiar faces in attendance. The patient is observed closely to provide protection from dangers of withdrawing or wandering away from the ward environment. The patient things are kept in a familiar position for easy identification. Items such as clock, calendars are kept at strategic position to assist in orientation. General nursing care as regards hygiene is also taken care of. Treatment of pressure areas, because the patients seem to lie on one side, so pressure areas should be taken care of. Bladder and bowel should also be maintained by making sure that the patient empty his or her bladder to avoid sore. Patient is also given nutrition diet or nutritious diet and adequate fluid. The nurse-doctor's relation should also introduce themselves to aid orientation. The nurse should be understanding and kind in taking care of this patient. Specific causes are treated with the use of antibiotics in the case of infection, anticonvulsants in case of epilepsy. A traumatic response may occur when ECG, except when contraindication, as in brain tumors. Also have drugs like chlorpromazine, which is 25 to 100 milligrams, may be prescribed 3 to 4 times a day. Also have here haloperidol, which is also given in divided doses, 15 to 30 or 20 in divided doses. Also have drugs here like diazepam, which is also given 15 to 40 milligrams in divided doses. Barbiturate also should not be prescribed, because there are people who cannot tolerate barbiturate. Also have supportive drugs here like vitamin B complex by IV, especially when vitamin deficiency is suspected. We also have here night care and observation, vital signs, general observations for the improvement drugs respond. We have psychotherapy, OT, occupational therapy, recreational therapy, when condition permits are necessary. Also have family and spiritual care. We cannot do without our God. So it is very important you call in their spiritual father. So always pray with them. Then rehabilitation and also discharge, which is the last word there. So that will bring us to the end of depression, where we have been able to discuss what depression is, the type of depression, the treatment, nursing care plan, and every other thing. So read it. Any questions, please ask or inbox me. You'll be answered. Thank you for listening.